Let's now talk about ALK disease, another subset of non-small cell lung cancer. This is about 4–5% of the patients. Once again, we've seen similar issues. We've had the first generation ALK inhibitor in ceritinib. Now in the second line setting, there are a handful of more potent second generation ALK inhibitors. Alectinib among them has shown data in the frontline setting. Ceritinib has shown data in the frontline setting. Again, which agent should be used first, which agent should be used second. Very similar kind of issues, but it's a fascinating time for patients and physicians to have all these options. So to take us through the data, maybe we start off with the ASCEND-4 trial, chemo versus ceritinib, which is now a new frontline option. Benjamin, your thoughts on the ASCEND-4 trial, and talk a little bit about the data, how this affects the landscape.
So ceritinib was the first to be approved 6 years ago, so it's yesterday, and now we have, as you said, a lot of drugs. So ceritinib efficacy is quite similar among all the trials. The PFS will be 11 months. In first line, ceritinib, a second generation inhibitor, gives us PFS of 16 months. Alectinib, a second generation inhibitor, gives us PFS in first line that is probably between 24 and 26 months. And there are other next generation inhibitor like brigatinib. Brigatinib is, we don't know if it's second or third generation, and lorlatinib. As we said for EGFR mutated NSCLC patient, it's a marathon. It's not only one line. And it's even more true for the ALK positive NSCLC patients, because all the retrospective series, and we see also with the first ceritinib Upfront study, the overall survival will be at least 5 years. And given the multiplicity of the TKIs, it may be more, and there is a huge French retrospective series from the expanded access program of ceritinib, more than 300 patients. In the patient that received 2 TKIs, the overall survival is more than 7 years. So it's true that all these new PFS are impressive, but we really have to put all these PFS in perspective of a very long overall survival. It's a marathon. We should probably not rush into the best drug up front. And I still think that ceritinib is a reasonable option in first line. We have to learn, as for the EGFR field, what is the mechanism of resistance, and maybe adapt the strategy based on that. A last word on ceritinib, because I had to comment the ASCEND-4 study. It's the usual dose for ceritinib is 550 milligrams. 750 milligrams per day. It's quite toxic. Usually you have to decrease to 600, maybe sometimes 450. And there are very interesting emerging data that shows that if you take the drug during a meal at 450, you have the same range of drug in your blood that if you take before a meal, 750, and the tolerance is much better. So ceritinib can be flagged sometime as a very toxic drug. I think it's unfair. Maybe the dose and the way we take the drug was not the right one, and I really think that we should really look at these data of low dose during meal, and it will be cost effective.
So 450 milligrams with food is effective as 750 with less toxicity. Now ceritinib in the ASCEND-4 trial had a median PFS of close to 17 months in the frontline setting, which is impressive. So it is in the US FDA approved for frontline treatment of ALK positive disease.